we started the Staphylococcus, and we discuss about the pathogenesis of this bacteria. We discuss about the diseases which is caused by the bacteria itself, and we also discuss the diseases which are linked with the toxins or toxinosis of this bacteria. So we discuss about the toxic shock syndrome, we discuss about the gastroenteritis, we discuss about the scalded skin syndrome. So today we'll start from the laboratory diagnosis, how we diagnose the bacteria in the laboratory. So this Staphylococcus, its main identification, it is identified under the microscope because of their colony morphology. So because of their colony morphology, we can identify this bacteria. This bacteria is a catalase positive, first of all. So that is, if you see here, this is catalase positive. And if you remember, I explained you what is catalase positive. So catalase positive is when we add hydrogen peroxide in the bacterial colony. So the bacteria convert H2O2. It convert the bacteria convert the H2O2 into oxygen and water. So oxygen bubbles can be seen here. So you see these bubbles. So these bubbles are actually the oxygen bubbles. So this is we call catalase positive bacteria. So this bacteria, it is a catalase positive. So this is one of the identification point. Second, this bacteria, it is Staphylococcus. It is has a branch just like a grape like branches. Under a microscope you can see this bacteria, and this is coagulase negative. So Staphylococcus aureus, it is coagulase positive, while the other Staphylococcus species like Staphylococcus epidermidis, that is coagulase negative. So Staphylococcus aureus, it is a coagulase positive. So this is a different. This is also a difference within the different species of the same genus. So Staphylococcus aureus, when we culture this bacteria, so the Staphylococcus colonies, they are yellow in color. If you see here, these colonies. So these colonies are yellow in color. So this is also one of the identification point for this bacteria. So Staphylococcus, it produce yellow color. So so that is why this bacteria is known as aureus. Aureus. Staphylococcus aureus. So Staphylococcus aureus mean golden color. Okay, the name of this bacteria, it is aureus because of its yellowish color colonies, and aureus mean golden color, golden. So that is why we call this bacteria Staphylococcus aureus. And this bacteria is hemolytic bacteria. It is hemolytic bacteria, and this bacteria, it can show a mannitol positive result. It is also a mannitol positive bacteria. So these are the differentiating point between this bacteria and other bacteria. So Staphylococcus aureus, it is it produce a yellow color colonies, that is actually we use for identification. So this and second, this bacteria, it is a mannitol positive. What do you mean by mannitol positive? The mannitol positive test is, it is we check the metabolism of mannitol. Certain bacteria, they ferment the mannitol. So that is, so why like this is like this test we perform. We add a mannitol in the bacterial culture, in a bacterial solution, and bacteria, it actually convert or it produce a acidic product. It produce a acidic product. And when we check the pH of a solution or pH of the colony, that is acidic. So that is we call a mannitol positive bacteria. So mannitol positive bacteria mean that it is actually the ability of certain bacteria to ferment this mannitol. Mannitol is a sugar. It's a sugar, and certain bacteria, they actually convert this sugar into a pyruvic acid. You remember glycolysis process. So through this glycolysis process, there will be a production of pyruvic acid, that is a acidic in nature. So when these bacteria, they ferment this mannitol, they produce a acidic medium. And when we check the pH of the acidic medium, pH of the medium of this bacterial colony, that is acidic. So this is also a confirmatory test for certain bacteria, because not all bacteria can ferment mannitol. So this bacteria, it is mannitol positive bacteria, because this bacteria can ferment the mannitol. Okay, so this bacteria is coagulase positive. This bacteria is catalase positive. It produce golden color colonies, so that is why we call them golden or yellow color colonies. So that's why we call them this bacteria aureus. And this bacteria is mannitol positive. So these are the four distinguished points for this bacteria, okay, for Staphylococcus aureus bacteria. Remember these identification points for the bacteria. So next is the treatment. So what is the treatment of this bacteria? As you remember at the beginning of this chapter, I told you about the antibiotic resistance of this bacteria. So this bacteria can acquire this bacteria has acquired a lot of genes, which make this bacteria resistant against almost all of the antibiotic available. So Staphylococcus aureus, when a patient, because it is pus forming, it is a abscess forming bacteria. So if there is any abscess, if there is lesion is there, Staphylococcus lesion is there, the treatment of choice is, first we need to drain the abscess. We need to drain the abscess. Drain means we need to remove the pus. We need to remove the pus. And second, we need to start the antibiotic. But the problem is with this bacteria is there is a antibiotic resistance. So according to their antibiotic resistance, actually acquired antibiotic resistance, we can classify this resistance into two categories. One is hospital acquired. I think it is mentioned here. Okay, yes, one is we call the hospital acquired infections, and one is community acquired staphylococcus infections, staphylococcus aureus infection. Because of their infection pattern and their resistant pattern, resistant to antibiotics, we classify these bacteria into community acquired antibiotic resistant bacteria and hospital acquired antibiotic resistant bacteria. Normally, because this Staphylococcus aureus, previously it was sensitive to penicillin, but now the bacteria has acquired a gene to produce some enzyme, especially penicillinase enzyme, or we can also call them beta lactamase enzyme. Beta lactamase enzyme or penicillinase enzyme, both are the same, okay, same enzyme but different words. Beta lactamase and penicillinase enzyme. This is the enzyme which is responsible for degrading the penicillin. So this is the resistant pattern of this bacteria against penicillin. So when this beta lactamase or penicillin, because they have this enzyme, so they degrade this penicillin antibiotic, and that is why they are now resistant against the penicillin. And even they are also resistant against methicillin and oxacillin as well. So I told you in our like at the beginning lecture, I told you about the methicillin resistant. So the bacteria, the Staphylococcus aureus bacteria, which acquired resistance against methicillin, that bacteria is known as MRSA. Methicillin resistant Staphylococcus aureus bacteria, MRSA. So if the bacteria is MRSA, it is MRSA positive, it means this bacteria will not respond to penicillin therapy, and this bacteria will not show any response against beta lactam antibiotics, all the beta lactam antibiotics. So beta lactam antibiotics are penicillins and cephalosporins. Cephalosporins are, these are the two groups we will study in detail in pharmacology about these antibiotics. Penicillin and cephalosporins, these are the two group of antibiotic which are known as beta lactam antibiotic, because these two groups have beta lactam ring in their structure, and this beta lactam ring is responsible for antibiotic activity. But this beta lactamase enzyme, it degrade this beta lactam ring. So when they degrade this beta lactam ring, this antibiotic will be of no use. There will be no use of this antibiotic. So the bacteria which has acquired this beta lactamase enzyme, those bacteria will be resistant against the methicillin, especially penicillin. So those bacteria will be known as MRSA, methicillin resistant Staphylococcus aureus. And because of this, and according to their resistant, MRSA can be classified into two types. One is community acquired MRSA, and second is hospital acquired MRSA. Community acquired MRSA, hospital acquired MRSA. So the patient who acquired the MRSA infection after admission into the hospital, that is known as, those patients or those infections are known as MRSA infections. The hospital acquired MRSA or hospital acquired methicillin resistant MRSA infection are those infections which are acquired in the hospital, which are acquired in the hospital. If you see here, this is actually the resistant pattern. So now resistant is increasing. Okay, so hospital acquired methicillin resistant Staphylococcus aureus infection, it is actually the infection which is actually this Staphylococcus aureus, which has acquired the resistant against methicillin or oxacillin. So that is why we call them MRSA. According to definition of hospital acquired infections, according to the definition of hospital acquired infections, the definition say that the hospital acquired infections can be classified as if a patient develop infection after admitting into the hospital within 48 hours. Like the patient enter into the hospital, and within 48 hours, if a patient develops some infection, that infection will be termed as hospital acquired infection. The same classification we apply for pneumonia, hospital acquired pneumonia. So if a patient develops pneumonia within 48 hours after admission into the hospital, then we call it hospital acquired pneumonia. So hospital acquired methicillin resistant Staphylococcus aureus, it is the infection which is acquired when a patient or a person enter into the hospital or admitted into the hospital. For example, one patient admitted into the hospital due to some other disease, but within 48 hours patient develop an infection, and that infection is a MRSA infection. Then this infection will be known as hospital acquired MRSA infection. And remember, hospital acquired MRSA infections are very much dangerous because there is a high chances or high rate of resistance in bacteria which are acquired in the hospital. This hospital acquired MRSA infections, uh, because this bacteria is resistant against methicillin, and this methicillin resistance, it is acquired by the bacteria due to chromosomal acquisition of gene, especially for protein binding, penicillin binding protein. So protein binding protein, PBP, it is actually a penicillin binding protein which is required for the penicillin activity. But due to change in this penicillin binding protein, due to change in penicillin binding protein, there is a antibiotic resistance. There will be a antibiotic resistance, especially against penicillin. So these penicillin binding protein, these proteins, they code for the new peptidoglycan transpeptidase. So that is why, because of their change in their activity, because of their change in transpeptidation, now if the bacteria acquired this penicillin binding protein mutation, so all the beta lactam antibiotics will be resistant. All the beta lactam antibiotic will be resistant. So bacteria will no longer respond against beta lactam antibiotic therapy. So if the patient develop MRSA infection, if a patient develop MRSA infection, it is life threatening. It's a life threatening infection because because there will be a worse outcome. Patient will develop toxic shock syndrome, and because the limited antibiotic availability, or even because of this resistance, maybe this bacteria is also resistant against vancomycin, that is the drug which we use for MRSA infection. As well as if a patient is on artificial ventilator, or if a patient already have some other diseases along with this infection, so there is a high chances of death, high chances of mortality rate. So as I told you that nowadays MRSA has been converted into VRSA. Now methicillin resistant bacteria, Staphylococcus aureus, now they have acquired a resistant against vancomycin as well. So we also have VRSA strain as well. So next we have community acquired MRSA infections. So community acquired MRSA infections, the patients with this community acquired, they have no longer any link with the hospital. So they acquire this MRSA infection from the community. So it's spread outside the hospital. So when you take the patient history, so patient will not give you any history of exposure to the hospital. So this community acquired MRSA infections, they were first documented in mid 1990s. And these community acquired MRSA infections, it occurs in those people who were not at the risk of MRSA infections, like those person who never went to the hospital, but still they got MRSA infection. They still got the MRSA infections. They never visited hospital, but they got this MRSA infection. So most of the common manifestation, like the patient have sign and symptoms, what MRSA can cause, community acquired MRSA cause. The community acquired MRSA, it cause skin and soft tissue infections. The most common one is cellulitis. My one auntie, she got this cellulitis, and it was like, it was hell to treat that infections, because there was a necrotizing fasciitis, and even the surgeon was thinking to remove or to amputate the leg, but thanks god, like now she is fine. So cellulitis, it may be a life threatening infection, especially if it is MRSA related. So MRSA, methicillin resistant Staphylococcus aureus, it community acquired. It mainly present with cellulitis or abscess. So patient may have some skin abscess or some boils, or maybe the patient have some cellulitis. Although there is a less chances of necrotizing pneumonia or any other diseases, but MRSA can also cause septicemia as well. It can also enter into septicemia. So there are some differences which can help to identify whether this MRSA infection is a community acquired or whether it is a hospital acquired. So there are certain differences between these two type of strain, MRSA strain. When we compare the DNA sequence of MRSA, community acquired MRSA, and the hospital acquired MRSA, so their DNA fragments are different. Okay, so when we, after this PCR or enzymatic cleavage, when we defragment the MRSA DNA of community and hospital acquired, their DNA are not same. They have different DNA sequence fragments. Along with that, the community acquired MRSA, although it is methicillin resistant Staphylococcus aureus, but community acquired MRSA may be sensitive to other antibiotic. For example, clarithromycin, fluoroquinolones, or other group of antibiotic. While hospital associated MRSA, it is resistant against all the other antibiotics as well, including this staphylococcus, including this methicillin. So this is also one of the difference between community acquired and this hospital acquired MRSA infections. I think here this table can help you to understand or to compare between these two infections. Okay, so for hospital acquired, because the patient first enter into the hospital, and once the patient is in the hospital, then the patient develop this MRSA infection. Even it is also classified that if you have visited the hospital within 48 hours, and within 48 hours you develop a, after visiting hospital, if you develop a infection, that is also linked as a hospital acquired infection. So most of the hospital MRSA patients, they are elderly patients or who are chronically ill patients, because their immunity is low. That is why they can acquire this infection very commonly, very easily. While community acquired MRSA, the patient is otherwise healthy. There is no any previous history. Okay, and maybe they are children, healthy individuals. Okay, they are healthy individuals, but this community acquired, it's spread within the community. So if one person, if one person at your home is infected with this MRSA, he can spread this MRSA to other people, other relatives. So that is why the military services personnel, students, like even if one student in your class is MRSA positive, then he can spread this MRSA to other student as well. So in community, the MRSA spread like this. So the infection site of this hospital acquired, usually the infection, the bacteria invade through the surgical wound, some ulcers, or maybe from catheter, it enter into the body, and then it cause the infection. While community acquired MRSA, mostly patients present with abscess or cellulitis, like skin or soft tissue infections. But patient may have septicemia, septic shock, or some bone and joint infection as well. So transmission of hospital acquired, like it mainly occur within the hospital or healthcare facility, while community acquired, it's spread in the community from one person to another, from one family to another, just like COVID-19. So for MRSA infections, if a patient who has a previous history of MRSA infection, if a patient who is having a MRSA history, like previously he was having a MRSA infections previously, then he will be have he will have more chances of recurrent MRSA infection when he again admitted to the hospital. If a patient is using antibiotic for a longer period of time, multiple antibiotic, the patient who are at the dialysis, or the patient who are inserting too much catheters like urinary catheter, nasogastric tube, intubation tube, cannulation. So if you are doing these cannulations or catheters again and again, so those patients will be at high risk. But community acquired MRSA, there is no any like medical history. Even they don't have any contact with any healthcare facility. So that's why we classify community acquired MRSA as a community acquired. So the virulence of this MRSA hospital acquired is like its spread is limited, and their PVL gene, pentone valentine leukocidin gene, is absent in hospital acquired. While in community acquired, the PVL gene, pentone valentine leukocidin gene, is present. So the antibiotic resistance in hospital acquired, the resistance, all of the antibiotics, they are resistant. So that is why we have limited choice for therapy. While community acquired, only methicillin resistance is there, but the bacteria can be sensitive to other antibiotic, not like hospital acquired MRSA. So these are the differences between hospital acquired and community acquired MRSA infections. So my vancomycin resistance is already been reported in 1997. Several isolates have been acquired that show vancomycin resistance. I have told you that if a patient is MRSA positive, then the drug of choice for the treatment of MRSA is vancomycin. So because of vancomycin resistance, now we have linezolid. This one, linezolid. But due to our use of these medicines, due to our use of antibiotic, now this bacteria is also resistant against this linezolid, also resistant against this quinipristin and dalfopristin or doptomycin. Daptomycin and vancomycin both are from the actually same class. That is also doptomycin, vancomycin, also cell wall synthesis inhibitors. So daptomycin resistance has also been reported. So it means that now we have MDR, not MDR, XDR MRSA, XDR Staphylococcus aureus infection. XDR mean that extended drug resistant, extended drug resistant Staphylococcus aureus infections. So all the antibiotics available, they will be there is no response. So we also have this type of Staphylococcus aureus, and that is because of the our use of antibiotic. Because we use antibiotic just like we are using toffees. Even you can buy the antibiotics from the pharmacy without any prescription. So everybody can go and buy. So that is one of the main reason of the antibiotic resistance. Okay, so how we can prevent the infections from Staphylococcus aureus? Like we can use some disinfectants, we can use some barriers, like if in the hospital, we can separate the high risk patients or a patient who is MRSA positive, we can isolate that patient. Okay, so we can isolate, we can make a barrier between the patients so that there will be a less chances of spreading. We can we use disinfection for our home. We can clean the surfaces. We can use some disinfectant at in the hospitals to decrease the chances of these Staphylococcus aureus infections. So next we have Coagulase negative Staphylococcus aureus. As I told you, Staphylococcus aureus, it is actually a Coagulase positive, but we also have Coagulase negative Staphylococci. So there are two Staphylococci which are Coagulase negative, although we also have other, but clinically there are two Coagulase negative Staphylococci. One is Staphylococcus epidermidis and one is Staphylococcus